Thank you, Rima. Thank you, Rima. Today, I'm very happy to introduce today's speaker, Hima. I've known Hima since 2004. She is OT, batch of 2004 from CMC. She graduated in 2009, and then she did her master's in psychology. She has also undergone Montessori training. And after her graduation, she worked for a year in rehabilitation center in Christian Medical College, Vellore. And from 2010 onwards, she's been working in neonatal ICU at Christian Medical College, Vellore. To quote Hima, her favorite area in occupational therapy is feeding interventions in infants, and her other areas of interest include developmentally supportive care interventions to reduce maternal stress and increase well-being in the mothers. She also conducts choir sessions for young children, and she plays the violin, piano, and the recorder. Hima has around 11 publications in her name in areas of neonatal care, especially early intervention and feeding practices in children. And I'm sure today's session will be useful to all of us. I welcome Hima to start the session. Hima.
Thank you, Anna, for that very nice introduction. Let me share my screen. Is my screen visible?
Yes, Hima.
Good evening, everyone. Thank you for this opportunity to share with you a little bit about what we've been doing in the NICU. And let me just start by thanking God, because for the past 12 years, it's really Him who has led me through. In my talk, I'll be briefly taking you through our NICU. Then I'll be briefly talking about developmentally supportive care, prediction of later neurodevelopmental outcomes, and briefly on early intervention and follow-up care. So our NICU is the only tertiary care center in a 270-kilometer radius. We conduct 12,000 deliveries a year, and there are 2,900 NICU admissions. We have 76 beds. Sick and very premature babies go from level 3 to level 2 to level 1. So in the level 3 NICU, what happens is invasive babies who require invasive respiratory support, ventilation, and life-threatening, when they have life-threatening conditions. Level 2 is still very intensive care, but less life-threatening. By then, this child is fairly stable. In level 1 nursery, the mothers basically learn how to take care of the infants at home. We also teach them things like how to give medicines, how to give pulmonary feeds, how to give the baby a bath, and how to schedule their routines at home. The picture on the right was the NICU level 1, which was really cramped pre-pandemic, and the one on the left is actually the mother's annex, which is a room that the mother stayed in previously, converted into a level 1 nursery for more space.
We cannot see your slide. We can still see your first slide.
Okay. I'll just go back to the level 3 and the level 2 pictures. So this is the level 3 nursery, level 2 nursery, which is slightly bigger, and level 1 nursery. Our caring clinic is our therapy room and our follow-up room, which was inaugurated around 3 years back. And caring stands for Center for Assessment, Review, and Intervention of NICU graduates. So our team, Allied Health team consists of 2 occupational therapists, a psychologist, a social worker, 2 critical care therapists, and lactation nurses. I'll start with the first topic, which is developmentally supportive care. Developmentally supportive care is basically an umbrella under which there are many different interventions that are required for the baby to develop optimally while they are in the nursery. It's important for developmentally supportive care, we have the cooperation of the entire team. The background behind developmental supportive care is that the intrauterine environment of an infant is very, very different from that when they are born prematurely and admitted in the NICU. The intrauterine environment has a fluid environment with increasing flexion towards term, with vestibular stimulation when the mother is walking, speaking, laughing, tactile stimulation simultaneously. The baby is shielded from light, and sound and language are at low frequencies. In contrast, when you look at the NICU environment, it tends to be noisy, chaotic, bright. There's decreased tactile input that is meaningful or non-painful. There's a decrease in flexion and lack of constant movement because of gravity. There are often frequent painful procedures which are more in level 3, less in level 2 and 1. There's constant interrupted sleep because of noise and sound, also lights. And infants who are sick or premature lack mature coping systems to cope with this chaotic environment. So developmentally supportive care is defined as the care of an infant to support positive growth and development while allowing stabilization of physiologic and behavioral functioning. We know through research that early life exposure predicts later life outcomes. And the NICU environment influences neural development during a very sensitive period of brain growth. We also know that the morbidity that we see in many sick or premature infants cannot be fully explained by a clinical course or a presence of brain injury. So 50% of premature infants without cerebral palsy show adverse neurological signs, which range from specific learning disabilities, low thresholds to fatigue, visuomotor impairments, emotional vulnerabilities. And this is just a few items off the long list. And these are things that are often attributed to the NICU environment. So Heidelisa Als, who's a psychologist, developed a theory of synactive, which she called the synactive theory of development. So she talked about the interdependency of motor, cognitive, and affective system. She said that if you look at this diagram on the right, she said that the state, motor, and autonomic systems in an infant are dependent on each other, where one changes in one of the states affects the other two. So, for example, if the child is undergoing a painful stimulation, it not only affects their autonomic nervous system, but also leads in motor behavioral stress and also their sleep and many other regions of their well-being. While we cannot prevent the child from having their painful procedure often, we can teach them compensatory strategies with the help of developmental support. And the goal that we are trying to achieve with this is to facilitate self-regulation, which is basically the ability of the child to maintain homeostasis even when the system is disturbed by a stressful event. And Heidelisa Als calls this a burden and an opportunity. A burden because sometimes you feel a little helpless about what the baby needs to go through, but an opportunity for us to intervene in a developmentally supportive way to help the child cope better, not just now, but also later on in life. So for example, if you look at signs of how can we make out that the child has stress or is stable? If you look at signs of neonatal stability in the autonomic system, you will find that the child has stable color, stable heart rate, respiratory rate, and feed tolerance. Whereas when the child is stressed, there will be color changes, alterations in heart rate, respiratory rate. Similarly, you can see signs in the motor and the state system. The impacts of stress and pain are enormous, and this is just a few of the findings that have been found. They found that greater number of painful procedures in preterm infants are associated with delayed postnatal growth, poor early neurodevelopment, high cortical activation, altered brain development, poor quality of cognitive and motor development of 1 year of age, and changes in caudal rhythmicity and caudal thickness in children even at 7 years of age. And this is just the tip of the iceberg. In order to practically implement this model of developmental care, they have described 7 core measures. And these are partnering with families as seen in the leaves of the lotus, positioning and handling, safeguarding sleep, minimizing stress and pain, protecting skin, and optimizing nutrition. At the center of this is promoting a healing environment where the child can optimally develop and providing the right kind of sensory stimulation. And I will be going through each of these 7 core measures one by one. So starting with the healing environment, ideally what we should do is we should protect the child's auditory system, protect the child's visual system, protect the olfactory, vestibular, tactile system, and provide skin-to-skin care as much as possible. So as therapists, when we look at protect, we wonder, okay, so what can we do? What are the interventions that we can do? So in order to understand that, we need to understand that the sensory system development has an order. It starts with the tactile system, almost 16 weeks post-menstrual age. That includes touch, temperature, pain, proprioception. And then comes the vestibular system, that's the sense of balance and movement, followed by the chemical senses, that's the olfactory gustatory system, followed by the auditory system, and the last, the visual system. And interventions that we do need to be timed to infants' readiness to accept and benefit from stimulus. For example, naturally, we would usually as therapists start in older children with the visual and auditory stimulation. But in premature infants, we need to remember that those are the last systems to develop. And therefore, the readiness to accept those kind of stimulation will come much later. So the goals of stimulation in the NICU are not just reduction, but providing positive, developmentally appropriate environment. This is done in an environment where the parents are engaged in the care of the infant and also in the stimulation. And the timing of the interventions need to be individualized and consistent, and the timing carefully planned. The main goals of interventions would be to promote normal motor and sensory processing. So what we try to use is the ladder approach. The ladder approach is basically a system that guides us in the intervention in an organized and predictable way. It takes place in the order of sensory system development, and the infant guides the intervention. We have the flexibility in the system to add or omit interventions that are not appropriate for any particular infant or are poorly tolerated. We always look for avoidance cues and coping skills, and they focus on the power of positivity in every interaction that we have with the infant. So the ladder approach looks like this. It starts with at the bottom of the ladder. We can start for stable infants around 29 to 30 weeks corrected age. We can start with tactile and proprioceptive input. I have not gone into detail of this, but we start with still, gentle touch, then we go on, progress to moving touch, and then a simple massage. If the child is able to tolerate this, we progress upwards the ladder to vestibular, later to olfactory gustatory system through feeding, and at the end, towards 36-week gestation, that's when the child is almost ready, almost at the corrected gestational age of 37 to 40 weeks with auditory and visual stimulation. So this is a systematic review which has looked at what interventions are effective for infants. So if you look at this, the continuum, this describes the post-menstrual age of infants. So the boxes, basically the green boxes show the interventions that have been found effective. The numbers inside the boxes show the number of studies that have been done in this area. And the red earmarked ones are the ones which have shown some caution. So if we look at this intervention, so if you look at tactile interventions, they can be started as early as 24 weeks, but there have been some reported adverse events, and probably safely start with 27 weeks. The earliest that can be started are the skin-to-skin interventions and gentle human touch, massage much later. I'm sorry. So then you have auditory interventions. Live recorded music can be started very early. Maternal sounds can also be started very safely and effectively from 27 weeks onwards. Visual interventions of cycled lighting, that is basically alternating the brightness of the light, having more brightness during the day and almost dim to no lighting at the night, have been found effective from very early. If you look at multimodal stimulations, AVTT is auditory, tactile, vestibular, visual interventions, which combines a number of different types of stimulation, have only been started 33 weeks onwards. And other interventions too, like massage therapy, which also include a visual and auditory stimulation, has been started much later effectively. So based on these findings, there's another protocol that has been developed, which I will not be going into too much detail, called the SENSE intervention. The second major area of developmental supportive care is partnering with families. We need to understand that there are stages that parents go through to regain parental confidence. In level 3, and when the child is in a very critical condition, there's the fear of losing the baby. This is followed by anger, depression, followed by cautious hope and emerging confidence. Later on, individualization of the infant and pride in the infant's individuality, and anticipatory guidance and follow-up. And what we need to do as therapists is guide parents through these different stages, leaving way for some of them to take longer in one stage than in the other, and helping them through different interventions come to the acceptance of hope and anticipatory guidance. So with regard to that, we have been doing some psychosocial support groups for mothers, which we all take turns in doing, where we allow them to share their difficulties, and we found that this is very effective when they know that they're not alone, and when others face the same difficulties that they have, it really gives them hope and encouragement. Another thing that we have tried to do is have activity group sessions. In one study done in our department, we found that when mothers attended activity-based group sessions once a week for 4 weeks, the post-test, there was significant lower anxiety levels when compared to a control group in the first, third, fourth sessions. And the post-test anxiety scores of the intervention group were significantly lower than that of the control group. We concluded that activity-based group therapy is effective as an intervention, and we had it regularly till the lockdown, and we are restarting it again now. But another thing that we found was that this reduction in anxiety level was short-lived in the study. The pre-activity anxiety levels did not change. So we realized that there was more that we needed to do for the mothers to improve their coping strategies and to provide more of an educational and behavioral change. So considering that, we developed a program or a module for education for mothers, which we call the NICU PANDA. So PANDA stands for Parent Administered Neurodevelopmental Activities. So what we have done is we've taken a program that was done in the Western population called COPE, and we modified it to make it simple, pictorial, and easily understandable, even with limited literacy. So this module covers things starting from what are the machines in the nursery used for, going on to how to position your baby. And it goes on to explain about what development is expected at what age, how to comfort your baby, how to identify stress signs, when to feed, etc. So we found that in a study, we found that using this intervention, compared to a control group, the group that received the intervention had significantly lower state and trait anxiety scores using the STAI, and they had much lower, significantly lower scores on the parental stress scale NICU. And we also found that compared to a control group, fewer mothers in the intervention group had bonding disorders. So this is another intervention that we have taken forward and have been incorporated into our regular therapy. Another major area of intervention is positioning and handling. So good positioning facilitates participation in normal sensory motor experiences. whereas poor positioning can lead to physiological distress and behavioral disorganization. There are studies which have looked at tonal development, and we know that it's in the third trimester that flexor tone develops in preterm infants. And unless they are positioned correctly, poor positioning has been associated with delay in motor development. So children are to be handled in flexion, containment, and alignment during all caregiving activities using slow, gentle movements, which are modified with each interaction to support symmetry. But we found that in our caring clinic, in our follow-up clinic, many of the babies came back post-discharge with severe plagiocephaly. Some of them also developed mild torticollis, and it was very difficult. Infants don't usually cooperate with stretching, so it was really difficult for the parents to do the stretching exercises for the infants. And we looked for ways to see if there was a way we could prevent plagiocephaly from the nursery, because that's where it started developing. So we looked at a study that looked at, so we did a study which looked at standard nesting alone versus standard nesting with a mustard pillow. So this mustard pillow has been traditionally used but never actually studied in our population. It's a pillow that's rectangular in shape and it's filled with mustard seeds. And it's an equivalent of the, we thought of the expensive positioning devices that were available in Western populations but not available in our population. So we looked at a group of infants that had the pillow and the group of infants that did not have a pillow. And we looked at 4 outcome measures. So the CVAI and the CI are ratios. They look at the, so the CVAI looks at plagiocephaly, which is basically a flattening of one side of the skull. The CI looked at whether there was a flattening at the back of the head or there was a longish shape of the head. The Argenda's classification was a visual classification of asymmetry, and the test of infant motor performance is a motor assessment. So we found that there was no difference in the CI index or the test of motor performance, but we found that infants in the intervention group had significantly lower incidence of plagiocephaly, looking at Argenda's classification and looking at the CVAI classification. So this is another intervention that we have started using routinely in the nursery. Another area that we is part of developmentally supportive care is safeguarding sleep. There has been shown to be a strong relationship between sleep and growth, including brain growth. Sleep deprivation is associated with increased pain perception. And what we try to do is support restful and uninterrupted sleep. This means that when we have we need to do an assessment for the infant or need to do an intervention. If the child is sleeping, we come back another time, or we come back later, and we try to club caregiving procedures. Another thing that we all try to do is whenever we see the baby for any intervention, we also change the napkin so that the child does not need to be handled again for a change. This is one area that we include in our mother's education too. We teach them the different stages of sleep, how to identify them, so that they know correctly when the child is ready to feed or be talked to or to be handled. We try to minimize noise and light as far as possible. Minimizing stress and pain is another very important area. We need to be aware of the infant's capacity to perceive pain. We need to be sensitive to situations of prevention. For example, if the child has just had a heel prick or just had an IV line insertion, we wouldn't immediately do any intervention after that or for a few hours after that, because then the child needs to recover from the painful stimulation before he can meaningfully respond to any intervention that we would try to do. We try to use appropriate assessment tools. Occasionally, we do get referral for assessing pain. We can recommend pharmacological interventions. This is especially for infants post-surgery. We can recommend the surgeons to provide the child with pharmacological interventions if we feel that the pain is too much. We can modify the techniques used for diagnosis or therapy. So we have changed to assessment tools which are hands-off as far as possible. We can provide environmental modifications like positioning the child in a way that is comforting, and we encourage the parental presence. So it is very scary when a child is in pain and the mother does not know what to do, but the presence of the parent actually improves the baby's well-being. So we teach mothers how to hold the baby so that they don't increase the pain but comfort the child, and we encourage them to be around as much as possible. So there are many non-pharmacological interventions that can be done. For example, sucrose can reduce pain for heel lance, venipuncture, intramuscular injections. Breastfeeding or breast milk can be given. This is something that we've been trying to use as much as possible before the child has an intervention. Skin-to-skin care can be used to reduce physiological and behavioral pain indicators. Non-nutritive sucking, swaddling, tucking, touch and massage. This is something that we do as well. We can do facilitative tucking, rocking, holding, and soothing vocal stimulation is something that all of us can do, which we also encourage everyone, including the nurses, to do, because it's just so easy and makes such a big difference. So looking at feeding, which is another major area of our intervention, preterm infants have many challenges in feeding, some of which are immature or absent coordination of suck, swallow, breathe patterns. This is especially if they've been born very early and if they've been on invasive respiratory support for a prolonged time. They're naturally hypotonic. They have more difficulty in arousal than term babies. They can be irritable, also because they've learned to be hypersensitive to oral stimulation because of medical intervention that may have been done. They can have behavioral disorganization, show frequent stress signs, and they can have poor endurance to feeding. So some of the feeding interventions that we do are non-nutritive sucking, assessment for feeding readiness, positioning during feed, provide oral support, and oromotor stimulation. For lack of time, I'm not going into detail of any of these, but the oromotor stimulation protocol that we use is the preterm infant oromotor intervention. This is, we have found this to be really effective, and so have other studies that have looked at this. It takes only 5 minutes and 2 minutes of non-nutritive sucking. One challenge, so when can we start what oral motor intervention? So non-nutritive sucking and oral motor stimulation can be started very early, up to 24 weeks post-menstrual age, when the child is in alert behavioral state, is physiological stable, and preferably from day 1 of life. So non-nutritive sucking can be done during tube feedings, outside feeding times. The mouth is never entered by force. And Western studies have always looked at it with a pacifier, but we usually do it with a finger. Oromotor stimulation can be done using gentle, firm pressure with 1 to 2 drops of milk introduced before every feed, and the mouth is never entered with force. Feeding is started according to a protocol that we have. If the child has started feed and is not able to safely or effectively feed, then we start on an oral rehabilitation program. So that would mean that the child is frequently physiological, is unstable, and has symptoms of stress, has feeding difficulties, and is refusing oral stimulation at 32 weeks and is not on full oral feeds at 35 weeks. Then we would assess more in detail and start movements which are individualized for these babies. So we face 2 problems with this. One is that we were not using pacifiers because our hospital is a breastfeeding friendly hospital and pacifiers are discouraged. And the challenge of doing oromotor stimulations just before the feed. So we did 2 studies, 2 very small pilot studies. The first one looked at oromotor stimulation administered by mothers of preterm infants. So we wondered if this intervention can actually be taught to mothers. The advantage was that they would be able to do it right before the feeds, like 5 to 10 minutes before the feeds, and they would be able to do it more frequently than we could if we were to do it on all the mothers. So we found that mothers were able to equally, there were no difference in the oromotor maturity and feeding performance of babies, whether the stimulation was administered by the mothers or by the therapist. We additionally found that the mothers were able to better identify the quiet alert state in infants when they did the stimulation and then fed the baby, compared to when it was done by a therapist. Another study that we looked at was non-nutritive sucking at the mother's emptied breast instead of a pacifier for non-nutritive sucking. And we found that when infants as small as 1.3, 1.4 were started on non-nutritive sucking at the breast, they were able to progress to breastfeeds much sooner and had more mature feeding skills when compared to infants who did not receive non-nutritive sucking at the empty breast early on. The seventh major area is protecting the skin. One thing that has shown to help with skin integrity is using oil for massage. We do not do this yet in our nursery, but we do advise parents to do it once they get discharged. As part of the team, we also monitor for nasal septum breakdowns, oral thrush, diaper area for rash, trunk columns for pressure, so ulcers, IV sites for erythema, and we promote skin to skin care. So another thing that we try to remember in the NICU is the rules of TENS. Rules of TENS is basically a way to evaluate bedside practices, decisions, and interactions. So what you do here is you ask yourself what you are doing for the baby, the intervention that you are doing for this baby, how will it affect this baby in the next 10 minutes? Then you ask yourself, how will this intervention affect the baby in the next 10 hours? And how will this affect this baby in the next 10 years? For example, if a baby is not ready for tactile stimulation, or you fail to recognize a sign of stress, how is the baby going to respond to your intervention in the next 10 minutes? And how is the baby going to be in the next 10 hours? And how is this learned pattern that they're learning that you are providing for them going to affect this child in the next 10 years? I find it a good rule to remember this with every interaction. So there are innumerable benefits of developmentally supportive care, some of which are decreased length of hospital stay, significant reductions in chronic lung disease, shortens the time to full enteral feeds, and improved neurobehavior, electrophysiology, and brain structure. Some long-term outcomes are improved neurodevelopmental scores between 9 to 12 months of age, improved attention, interaction, cognitive planning, affect regulation, fine and gross motor modulation, better auditory processing and speech at 3 years, fewer behavioral problems and better infant-mother communication, and higher survival rates and attention deficits at 6 years. So going on to prediction of later neurodevelopmental outcomes. So this is actually a set of triplets. One of them had a grade 3 IVH and was under our very close, careful monitoring. And the picture on the left is at 1.5 years when we did a Bailey assessment for them, and all 3 of them were doing good. This is a really nice, happy story. But sometimes with all the babies that we see in the nursery, with the huge amount of babies who get discharged, we are not able to differentiate which are the babies who really need a close follow-up and which are the ones who will do all right. So why do we need a very early assessment? One is to be able to see, to be able to predict which are the babies at highest risk of poor neurodevelopmental outcomes, and to discriminate between which infants may need only minimal support and which infants will need more intense care. To evaluate change of an intervention, so when you've taught a program or an early intervention, to see how much the child has improved, to initiate and progress early intervention services, to make a therapy plan for the child, and also to inform the clinicians and parents, because the most often the question that you get to ask, that you are asked is, will my child be all right? So some of the assessments that we use are the Amiel Tison Neurological Assessment, the Hammersmith Neonatal Neurological Assessment, the Test of Infant Motor Performance, the General Movement Assessment, and the Alberta Infant Motor Scale. I will be going through the first through assessment very briefly, but what I will do is I will, at the end of the presentation, put in a resource slide where you can learn in more detail about all of these assessments. So the Amiel Tison assessment is what we use for all infants pre-discharge. It has 6 areas. So it looks at head growth and cranial sutures, alertness and spontaneous activity, passive and active muscle tone, primitive reflexes, and feeding autonomy. And each item in this scale is scored as 0, 1, or 2. And at the end, you classify the child as either normal, mild, moderate, or severe neurological impairment. And this kind of gives you a guideline about when and how often you should call this baby back for follow-up care. The Hammersmith neonatal neurological assessment is another assessment that we occasionally use. It can be done from birth to 21 days in term babies and from 37 weeks to 42 weeks in preterm babies. It also looks at 6 areas, that's posture and tone patterns, reflexes, movements, abnormal signs and patterns, and orientation of behavior. And it has a scoring system which looks something like this. So it is pictorial, and this is the first item that the scale has, and this looks at posture. So you would look at this baby and you would score this baby probably here or somewhere in between these two. And a term baby like this, you would probably score here. So how you score this assessment is that this would be 1, 2, 3, 4, 5. And there are tables where you can interpret the scores and you get a final score. And a score of above 30.5 or 29.5 for preterm babies indicates a normal neurological assessment. This is a little more time consuming than the amyloid. The third assessment that we often use is the test of infant motor performance. This is a test where you look at posture and control of movements. It is one of the earliest assessments that can be used. So you can start using it from 32 weeks post-conceptional age till about 4 months post-term age. So you can look at interventions that you've done and how much the baby has improved. You can discriminate different degrees of poor motor outcomes. It predicts 12-month motor performance and preschool motor performance fairly well. It has 28 observed items and 31 elicited items. And it looks like this. The picture is not very clear, but it is pictorial. So you would place the child in a particular position, give a stimulation, and wait for the child to respond. The test items are very simple and easily available everywhere. And according to the scores that the child gets, you can classify them as average, below average, or far below average. So using the TIMP, they actually found that children who later developed CP had there were some items that were clear indicators. For example, between 2 to 3 months onwards, they had difficulty keeping their head in midline. From about 1 month onwards, they had poor anti-gravity movements of the arms, poor head alignment while rolling from the legs, and they had increased in neck extensor tone when placed in prone, and they had good, better than average till the end of 6 months. So it's shown to have a very high specific predictive value for normalcy, minor neurological dysfunction, and CP. So this one study, which looked at tests to predict cerebral palsy in young children, found a very high sensitivity and specificity for general movements in prediction of CP, which is almost in par with that of a neurological, in par with an MRI, and much better than a neurological assessment or a cranial ultrasound. And we have actually found similar findings in one of the studies that we have done. So general movement assessments. This is a child who's around 12 weeks post-term age, who has normal fidgety movements. So these movement seconds that the child has last few seconds to few minutes. And if you look at this child, he's got very nice complexity, variability. The movements are very fluent and spontaneous. But the absence of these qualities of complexity, variability, and fluency are associated with adverse neurological outcomes. So if you see this baby has very nice trunk, hip, shoulder, very fine, nice movements of the toes, the fingers, the wrists. So if you look at the timeline where general movements occur, preterm movements start almost around 8 weeks post-conceptional age, and they continue unchanged in form till around 45 to 50 weeks post-menstrual age. So they change slightly in form and are called riding movements after around 37 weeks. And from this age onwards, they are labeled fidgety movements. So they can be classified as normal or abnormal in the riding or preterm movement or in the fidgety movement period. After around 60 weeks, what happens is that the voluntary and anti-gravity movements take over predominance and reduce, the fidgety movements are reduced. So going on to early intervention and follow-up care. So high-risk infants are defined based on either birth weight, gestational age, or other medical conditions like a major surgeries, seizures, serious illnesses like meningitis or congenital malformations. We have developed in our department a protocol for which are all the babies who need follow-up and are classified as high-risk infants. And all these babies who are classified as high-risk infants have a blanket referral for occupational therapy. Other family variables that we look at are postpartum depression, major psychiatric history in one of the parents, or a developmental disability in either one of the parent or the siblings. So what we do, this is according to our protocol. Before discharge, we do an MELT zone. Until 3 months, we do neurological assessment, that is tone, reflexes, movements, and developmental milestones. At 6 months, 9 months, and 1 year, we do the Denver Developmental Screening Test 2. At 1 year corrected age, we do the Peabody Developmental Motor Scales, and we do the Language Evaluation Scales Trivandrum, because the Peabody contains mostly motor scale, is a motor scale, and sometimes we tend to miss out early signs of autism or language delay. At 1.5 years, we do the Bailey scales of infant and toddler development. At 3 years, actually, our psychologist takes over. So she does the WIPSI, and we do a simple test for fine motor coordination. At 4 years and 5 years, we do developmental screening. At 7 years, we do a formal WISC. And at 7 years onwards, every 2 years or so, we do a development screening. And BMI or a BOT, that's a Bruin's or Stress test of motor proficiency, if indicated. So our intervention plan is that early stimulation is taught in the nursery when the baby is ready. Before discharge, we give them an early intervention home program, and therapy, when they come for follow-up assessments, we do as indicated. And we refer to the developmental pediatric unit for therapy if there is a sign of early CB at 1 year. So the 2 neurodevelopmental assessments we do post 1 year are the Peabody motor scales and the Bailey scales of infant and toddler development. We try to have a NICU graduates reunion once a year. It's an annual gathering for high-risk infants. So what we try to do is we explore difficulties in parenting or child development. We try to see what strategies healthcare professionals we can use to build better support systems for the family. And we provide opportunity to assess infants, so that this provides us for an opportunity to assess infants who are lost to follow up. So we found that in one study, we looked at why parents were finding it difficult to come back for follow-up to the NICU. We found that some of the strengths that we had were family support, awareness that the child needs to come for follow-up, and mothers who are very determined to bring their child regularly for follow-up. There were a lot of challenges, which include societal attitudes, guilt, blame on the mother, exploring alternate treatment methods, families who don't believe in follow-up, financial aspects, distance, wanting the same therapist or doctor. So these are all things that contributed to the experiences of follow-up care in our mothers. And we realized that it's not just that we have to educate the parents, that we also have to educate the whole family regarding the child's condition and continuously support them even after discharge. So concluding, being an occupational therapist in the nursery has been extremely rewarding. It's wonderful seeing children who are very sick recover, do well, not just survive, but thrive. And it's amazing to have the power to make a difference at this early stage of plasticity, where we still can make a change for the infants. It can be heartbreaking at times because that's a characteristic of our profession, I think, that we see continuously people who are suffering in pain. There are challenges and rewards of working in a team. There are challenges of getting everyone to come to the same conclusion, but there's a reward because we all work towards the well-being of the infants. And I feel like compared to all the other professionals who work in the NICU, OTs, we have a unique lens because we look at this infant and we think about them 10 years down the line. So we think, how is their attention going to be, and how are they going to cope with stresses in life? How is their emotional regulation going to be? And things like that, which is very unique to our professional, I think. And being in the NICU is a continuous learning process. So each baby is different, and you are continuously learning something new every day. So I've left this slide with resources. So the Amiel Tisson can be, you can read the book and actually do it if you have some experience in handling infants. The Hammersmith Neurological Examination, if you go on this webpage and if you register, you will get free videos on how to do the Hammersmith Neurological Examination. The TIM has to be purchased, but with the purchase, you get a CD which teaches you how to do the TIM. You can also register for online courses. General movement needs certification. So this website actually gives the dates, which includes some workshops in India. I think there's one in Mumbai the end of this year. Bailey also needs training. Oromotor stimulation, you can do a PYOMI training online through a webinar. I've put my email address here. So if you would like to have more resources, you can mail me and I could help you with the resources. So thank you.
Thank you, Hima. Now the floor is open for discussions. Those who have doubts or queries, you can either unmute yourself and ask them, or you can type it in the chat box. Hima, let me start by asking you, could you please elaborate on the infant massage that you given? You just touched upon it, the ladder approach. You said that you would start with gentle touch and the infant massage, right?
Yeah.
So how exactly would you do it?
Okay, so we start with, so we use moderate pressure. We do not use oil while they're in the nursery. We start with the parts of the body that are least sensitive. So we avoid all sides of IV lines, any, if they've just had an IV removal, we would avoid all those sides. We do not, we teach the mothers to repeat each movement 3 to 4 times. If the child likes a particular movement, they can repeat it more times. We have a protocol for that. I can share it if any of you are interested. So we teach them the steps. We ask them to start with gross movements, and before discharge, we teach them one that is more in detail.
Okay. Yes, Manisa has raised his hands.
I just wanted to congratulate Hima on doing this wonderful presentation. I didn't have any much question to ask anyway. The reason why I was actually raising my hand is to simply congratulate and again talk a little bit about the area that you were one of the systematic reviews that you were saying, the kangaroo care is having quite a few difficulties at the early stages. I know I have no idea about preterm or infants, or forget about infants, even children for that matter. And just wondering, like, if you could share your experience, because there is quite a lot of evidence suggesting that, kangaroo care seems to be quite very widely accepted as an effective intervention protocol. So any experience that you could probably share, please.
So this is actually kangaroo care is extremely effective in helping with not just the child's neurodevelopment, but also with feeding intervention, because it makes this baby very comfortable with the mother. So prior to lockdown, prior to the pandemic, the mothers were doing it multiple times a day. It's recommended that you do it more than 45 minutes. So they would actually be in the nursery, give kangaroo mother care for almost an hour, 1.5 hours, speak to the baby while doing the kangaroo care. We had to stop it when the pandemic started, because our nursery does not, it's an open room, and there was a worry about spreading infection. So we still have not restarted it, unfortunately, but I can see that the effect it had on the lack of it had on feeding. So now, since the mothers don't start kangaroo mother care so early, they are more anxious while handling the infant when they start feeding. So that's something I think that, like, probably we should urgently restart. It's very simple. So the child wears a napkin, and the child is placed between the mother's breasts, and the child is covered with a blanket from the outside. And initially the child fights a little bit, because the warmth is slightly more than the child's temperature, but after a few minutes you can just see the child relax. And we used to have many mothers like singing while they're doing kangaroo mother care. It used to be a very nice experience. So that's something that unfortunately we stopped at the moment, but really need to urgently restart.
Thank you, Hima.
Hima, the graduates from the nursery, how frequently do you ask them to come for reviews? Like, is there a timeline, like every month or every 6 weeks? Is there something like that, or just you gave a table of assessments at what age you would ask them to come? Is it like that, or how frequently do you ask them to come?
So they come at the first follow-up visits, which is a week within discharge, where they also come to meet the physicians in the high-risk infant clinic. So we find this helpful because it's their first transition to home, and there are a lot of problems usually behaviorally when the child transits from the nursery to home, which we are able to address at their first visit. After that, if the neurological assessment is normal, we see them only after 3 months. So then we see them 6 months, 9 months, 1 year, and then 1 year corrected age for a Peabody, 1.5 years for a Bailey. At the Bailey assessment, we usually decide whether they need more detailed intervention, then they go to developmental pediatrics, or we follow them back at 3 years or so. Yeah.
So till 3 years of age, the neonatal therapy department, I mean, you do the reviews, is it? Or
if they are near normal, if they have no major developmental needs, then we see them.
Okay. Are there any other questions?
Yep, Anna, I have.
Yeah.
This is Joshua here. Oh. Hima, you have done a wonderful presentation, and my question was one of the slides you were talking about children with cerebral palsy and how they respond while they are in the neonatal unit. Do you have similar studies for children with autism? Because there was another slide you were talking about sleep deprivation and brain development and growth. So do we have any studies, or are you thinking about it's a scope to do some studies on this area?
So there is studies have shown a clear association between preterm infants and children with autism. So in one study that we did, we looked at general movements in the preterm infant period. We did 3 movement assessments. So one in the preterm period, one around term, and one around 10 to 15 weeks corrected age. So in the 3 assessments, we actually did not pick up 3 children who later developed autism. We did pick up 2 children with cerebral palsy. So there are some studies which have shown, I think there's a very recent study which has looked at attention in infants and later autism, and they found a clear association. We have not done anything similar. This is something probably it's a very good area to research, and we should look at it. It's an area that we should explore more, especially since I think more and more children are later diagnosed with autism, even in India, and many of them are our NICU graduates. So that's something that we should explore.
Thanks, Hima. I will write to you more about this.
Thank you.
Any other questions? I know that many students from other colleges are also attending this webinar. So I would encourage you to make use of Hima's expertise and ask questions and learn from her.
Okay, I'm going to probably again commend the work that she has done. Hima, looking at the publications that you've got and the information that you shared today, I did put that up on the chat there. You have enough and more information to write several books, forget about one there. So you know, I'm going to continue on what Joshua is talking about in terms of doing research. It looks like you may have you know, research. If you start writing it up, you might probably be having too much to write, and probably will be sitting there writing every half an hour a publication, and it is fantastic. That's fantastic. I have no other words to explain.
Thank you, sir.
Hima, that was a wonderful session. I think we should have more sessions from you. You know, today you just gave us an outline of NICU care, maybe more on feeding, more on the ladder approach, you know, 1 whole hour for each of the topics, each of the headings that you've given. And, you know, as you, many of the, in the messages, you know, what people are saying, you have, you know, I'm very proud to know you. And the presentation was awesome. Thank you so much. Now I hand it over to Rima, the president.
Thank you, Anna and Hima. One of the reasons why I had requested Hima to talk on this topic was because we constantly get a feedback that, you know, when it comes to other conditions, OTs have a general idea of what to do. But when it comes to children in the NICU, that is something that a lot of people say that they do not have enough background in. So that is one of the reasons why we had thought that it would be good to have this. I've also been privileged not just to know Hima as a colleague, but also as the mother of a preterm infant who she was the occupational therapist for my son also. And over the last few years, I've also been very lucky to work with her in some of her work in terms of supporting the mothers of preterm infants. So again, once again, thank you, Hima, and also Anna. You were asking Hima also to have webinars. I would also say you should also be one of the speakers for one of the coming webinars, because you also have a lot of expertise. So thank you all for attending. If any of you have any further doubts, you can reach out to OPTAA, or I shall share Hima's email ID if she's okay with it. The coming webinar for the month of June will be by Mr. Roger. He's our physiotherapy alumni, batch of 2006. And he'll be talking to us about sports physiotherapy. So that's all from my side. Thank you all for joining in, and see you next month. Have a great month.